Hello, my name is Chidozie Menakaya, and I'm a pharmacy student. And with me, I have...
I'm Rachel Donnelly. I'm a nursing student.
And today we're going to talk about our patient BM and his different medical information. So, our objectives for BM include to identify subjective and objective data for his chronic pain medication, and based on primary literature, recommend appropriate drug therapy for his opioid-induced constipation, and to create a monitoring and patient counseling plan for his opioid-induced constipation. Now, BM's chief complaint today is he says, my pain medication constantly gives me constipation issues. BM is a 67-year-old retired male with chronic back pain for the past 20 years following 2 car accidents. BM takes Ultram every 6 hours to control his pain, which emerges as a dull, aching pain in the middle of his back and is made worse with stress. The pain can radiate to peripheries as a burning pain if not controlled with his medications. The pain has been the same for the past 20 years, and BM says Ultram works for him the best, despite the side effects that he experiences just as opioid-induced constipation. He tries to take Norcor at a minimum to avoid drowsiness due to medication. Now, his past medical history include benign prostatic hyperplasia, chronic back pain, GERD, hypertension, dyslipidemia, and a stroke he experienced this February. Now, his past surgical history include 2 herniorrhaphies, one 30 years ago and then second 20 years ago. And he also had his gallbladder removed. Now, for family history, which is non-contributory, he says his wife, son, and daughter have no diseases or conditions. His dad passed away at the age of 70 due to kidney failure, and his mom passed away at the age of 72 due to oral cancer.
And some social history that we have for BM is that he has a sedentary lifestyle of limited physical activity due to his retirement. He does not smoke or drink, but he does have a poor diet. He lives with his wife and son. They have no pets, and he does not have any allergies that he's aware of. Some of the medications that BM is on include hydrocodone acetaminophen, tramadol, milk thistle, aspirin, calcium citrate, tamsulosin, atorvastatin, and terazosin, which he was previously taking for his BPH prior to his meds being changed. So we have our review systems and musculoskeletal system, his back pain. So patient reports a certain degree of limitation of his motion, but it does not interfere with his ADLs. Patient reports good control of his pain with his medication, aside from the aforementioned issues. Gastrointestinal system, he reports that he has constipation related to his pain medication. He also reports that he has frequent heartburn due to his medical diagnosis of GERD. For physical exam, which we were unfortunately unable to do, but what we would want to do is we would want to do an examination of his abdomen, which would include inspecting for any distension, listening for his bowel sounds, percussing and palpating the abdomen.
And focusing on our assigned problem today, which has to do with his chronic back pain, we're focusing on adverse drug reaction as the medication-related problem due to his opioid-induced constipation. Now, the subjective findings that we have are abdominal discomfort, hard stool, pain while defecating, and difficulty defecating. And then for objective findings.
So what we would have from the examination would be basically if he had any distension from being constipated, from percussing, if he had any blockages.
And our assessment for our patient is that BM is a 67-year-old man with chronic back pain for 20 years. He has been taking Ultram and Norcor for treatment, and due to that he has been suffering from opioid-induced constipation. He has tried laxatives and stool softness with little results from the medication and still suffers from opioid-induced constipation. Studies have shown that metronidazole is a more effective agent to treat opioid-induced constipation, and it comes in a subcutaneous form, and it is our plan to give this to our patient. Now, the goal of therapy for our patient will be to relieve the patient from constipation disturbances, to improve BM's diet, and to initiate a daily exercise regimen for BM. And a pharmacological plan would be to give BM a subcutaneous form of metronidazole and also have him retain his use of laxatives as a rescue agent. And for the non-pharm plan, we'll have Rachel talk about that.
Okay, so as part of our non-pharmacological interventions, we would want to encourage a fluid intake of about 6 to 8 glasses of fluid per day, as long as it's not contraindicated with his medications. We would also want to encourage a fiber intake of 20 grams per day. Hopefully that is palatable for him, so to encourage compliance. Also, this would need to be with appropriate amount of fluid intake as well. An excellent source for this would be prunes, which have 6 grams of fiber and also have numerous beneficial laxative effects for him. So we would also want to teach our client to respond to the defecation urge and to avoid straining, as this can result in cardiac dysrhythmias and fainting, which can result in injury.
And then for monitoring parameters, we're going to monitor for bowel movements. We're going to check for abdominal pain and discomfort. We're also going to monitor for possible diarrhea from the medication. Efficacy, we're going to go based on a reduction in the occurrence of constipation and a reduction in the number of times that BM uses his rescue laxative. For toxicity and adverse effects, we're going to be mindful of diarrhea and abdominal pain from the metronidazole as an adverse effect. And we plan to follow up with BM in about 2 weeks to make sure that his plan is working well for him.
And as I said before, just to reiterate, we want to provide education about how to improve his diet, to help with the constipation, and to avoid certain behaviors such as the straining and the resisting the urge to defecate.
My name is Sarah, I'm a pharmacy student, and I'm going to be talking about the same patient, BM, but with the topic of BPH, or benign prostatic hyperplasia. So my objectives for this disease state are that to identify subjective and objective data for BPH, and based on primary literature, recommend appropriate drug therapy alternative for uncontrolled BPH with the tamsulosin use, and to create a monitoring and patient counseling plan for a patient to receive the alternative doxazosin extended release for BPH. So BM's chief complaint regarding BPH is that I don't think my prostate medication is working well. I still experience urgent urination and difficulty urinating. So for the history of present illness, patient BM is a 67-year-old retired male with diagnosed BPH, and he has had it for the past 4 years. He experiences urgent urination and has difficulty voiding due to the increased pressure. He previously took terazosin for his BPH prior to a stroke in February of this past year, and he said that it didn't work for him. He researched tamsulosin online and heard that it worked, so he contacted his doctor after his stroke to change the medication. But he also states that he's still increasingly feeling difficulty urinating and that it takes him a long time to completely void even with the new medication. And he also states that he has not experienced any further changes in his blood pressure, which is still 150/92. And he does not take any separate medication for his blood pressure. So the other medical information that we mentioned earlier, such as the past medical history, is all the same. And Rachel's just going to go into the review of systems.
Okay, so we have our urinary system review. Patient reports frequent and urgent urination. Patient also reports general difficulty urinating.
Okay. And for laboratory data that we do not have any available, but we would like to see an electrolyte panel and also BUN and creatinine so we can monitor the kidney function based off of the new therapy that we would want to give him. And for a diagnostic test, they also were not available, but we would like to see an annual PSA and DRE screening to monitor for prostate cancer and also to monitor the efficacy of whatever medication he is taking. And we would also want to see uroflowmetry and pressure flow urodynamic studies, as well as having the patient fill out a AUA symptom index questionnaire, which would also help us monitor his therapy. So now onto the problem list. For BPH, the problem is that the tamsulosin dosing regimen is not optimal. It can be increased to 0.8 mg milligrams from the 0.4 that he's taking. And another problem could be that tamsulosin drug selection is not optimal, so we can switch to a more effective alternative, such as doxazocin extended release. Now, to the SOAP. For the subjective information, we have that the patient has BPH, and he previously took tamsulosin 0.4 milligrams by mouth daily. He previously took terazosin, doses unknown, but he did not feel any relief of his symptoms. He's continued to experience urgent urination and difficulty urinating even with this tamsulosin. And he has been taking the new tamsulosin medication since February after a stroke. For the objective information, we would like to see, as mentioned earlier, the PSA and DRE screening results, as well as the uroflowmetry and urodynamic studies, as well as questionnaire information. So for our assessment, BM is a 67-year-old man with BPH for 4 years. He has been taking tamsulosin 0.4 milligrams daily since February of this year. He previously took terazosin to manage his BPH, but he experienced no relief of symptoms, and he continues to experience urinary urgency and difficulty voiding. Drug therapy for BPH includes alpha-1 adrenergic antagonists that relax the smooth muscle on the prostate, improving urine flow. And so that is what I will be recommending. BM can benefit from either a dose increase of tamsulosin to maximize therapy, or a change of therapy to doxazocin extended release, which could be indicated as it has been proven to have greater efficacy at improving urinary symptoms. So on to the plan. For goals of therapy, we want to relieve his irritative voiding symptoms, to increase urine flow rate, and to improve lifestyle to coincide with therapy to further improve the BPH symptoms. For the pharmacologic plan, we would want to either increase tamsulosin from 0.4 milligrams to 0.8 to maximize therapy, or another option supported by literature is to discontinue tamsulosin and to switch to doxazocin, the ER formulation. Now Rachel is going to talk about the non-pharm plan.
Okay, so some non-pharmacological interventions we have regarding BPH, or the obstruction of the urethra. We could ask our client BM to keep a bladder diary, keeping track of his urinary elimination patterns in order to better monitor and effectively plan care for him. Also, we would want to advise him to avoid certain risk factors associated with retention, including avoiding over-the-counter cold remedies containing decongestants or antihistamines with anticholinergic effects. Discussing problems with his primary care provider before starting new prescriptions, warming the body before attempting to urinate after being prolonged exposure to cold weather, and avoiding excessive alcohol intake, maintaining regular urination patterns.
Okay. And for the monitoring parameters, to monitor for efficacy, it's the same as what I mentioned earlier. We would want PSA and DRE screening to monitor for cancer and for efficacy, as well as the AUA system index questionnaire. For toxicity, for the doxazocin medication would include first dose syncope, orthostatic hypotension or dizziness. And for follow-up, we would want to schedule a visit within 2 to 6 weeks, because that is when you see the efficacy of this medication, just to see how the patient is responding to therapy. And we would also want to make sure to regularly monitor blood pressure, since hypotension is one of the adverse effects. And for patient education, we would tell the patient that they will see peak symptom relief within 2 to 6 weeks, and that they should take the medication at bedtime to avoid hypotension symptoms. And you have anything to say?
Just to, as I said before, provide the client with education about things that he should maybe avoid.
So it was really helpful having a nursing student with us, Rachel, to help us with this project. Especially was helpful for me for the review of systems and the physical examination, because there's a lot of details in there that I wasn't really aware of or how to approach it. And also in the non-pharm, it was very, very helpful to have Rachel's input on that.
Yeah, It was good to see how the different aspects of care were sort of integrated in the way one supports the other, especially with the non-pharmacological interventions, how they complemented the pharmacological interventions. So.
And it optimized patient therapy for the care plan that we made.
For working with Rachel on this project, I really got to see the nursing side of it. I liked her input on the non-pharm with the auscultations with the abdomen, and that was really cool. So I really valued her input, even when she talked about checking for objective findings. You have to have the patient in front of you, bowel sounds, and the non-pharm. She even had the grams of the fiber that you should have. So it was really good having her in there.
Yeah, and I learned a lot all about the new pharmacological interventions. I think I was a little behind in the times, so you guys really caught me up.
Yeah, it was good working together.